part 9 of chapter 14 gets into pharmacoeconomics, page 222. So the background here is, as we know, healthcare costs in the United States rank among the highest of all industrialized countries. In 2017, total healthcare expenditures reached $3.5 trillion, which translates to an average of $10,739 per person, or about 7.9% of the national gross domestic product. The increasing costs have highlighted the need to understand how limited resources can be used most effectively and efficiently in the care of individual patients and society as a whole. It is necessary to scientifically evaluate the value, so for example, costs versus outcomes, of interventions such as medical procedures or drugs. So let's go through some definitions. Pharmacoeconomics is a collection of descriptive and analytic techniques for evaluating pharmaceutical interventions. Examples include drugs, devices, procedures in the healthcare system. Pharmacoeconomic research identifies, measures, and compares the costs, direct, indirect, and intangible, and the consequences, clinical, economic, humanistic, of pharmaceutical products and services. Various research methods can be used to determine the impact of the pharmaceutical product or service. These methods include cost-effectiveness analysis, cost minimization analysis, cost-utility analysis, and cost-benefit analysis. The term pharmacoeconomics is sometimes referred to as outcomes research, but they are not the same thing. Pharmacoeconomic methods are specific to assessing the costs and consequences of pharmaceutical products and services. Outcomes research represents a broader research discipline that attempts to identify, measure, and evaluate the end results of healthcare services. Healthcare providers, payers, and other decision makers use these methods to evaluate and compare the total costs and consequences of pharmaceutical products and services. The results of pharmacoeconomic analyses can vary significantly based on the point of view of the analyst. The study perspective is critical for interpretation. What may be viewed as good value for society or for the patient may not be deemed as such from an institutional or provider perspective. For example, the costs of lost productivity due to illness are critically important to a patient or an employer, but perhaps less so to a health plan. Pharmacoeconomic analyses provide useful supplemental evidence to traditional efficacy and safety endpoints. They help translate important clinical benefits into economic and patient-centered terms, and can assist providers and payers in determining where or if a drug fits into the treatment paradigm for a specific condition. Pharmacoeconomic studies serve to guide optimal healthcare resource allocation in a standardized and evidence-based manner. So the ECHO model, which is economic, clinical, humanistic outcomes, provides a broad evaluative framework to assess the outcomes associated with diseases and treatments. So when looking at economic outcomes, this would include direct, indirect, and intangible costs of the direct use of the drug compared to a medical intervention. For clinical outcomes, this includes medical events that occur as a result of the treatment or intervention. With humanistic outcomes, this can include consequences of the disease or treatment as reported by the patient or caregiver. So for example, patient satisfaction, quality of life. Page 223, we have average and incremental cost-effective ratios. So the results of a pharmacoeconomic analysis are commonly expressed in terms of a cost ratio, representing the cost incurred to achieve a particular outcome. So for example, cost per case cured, cost per treatment success, cost per quality adjusted life year, QALY. So cost per quality adjusted life year that is gained. Two fundamental cost ratios are commonly used to communicate results of these pharmacoeconomic analyses. This is including the average cost effectiveness ratio and the incremental cost effectiveness ratio. So the average cost effectiveness ratios. Average cost effectiveness ratios reflect the cost per outcome of one treatment independent of other treatment alternatives. So for example, if a treatment costs $50 to generate successful outcomes in 2 patients, the average cost effectiveness ratio is $25 per treatment success, or 50 divided by 2, since there were 2 successfully treated patients. The next one we're going to look at is the incremental cost ratio calculation. So let's look at the ratio. This represents the change in costs and outcomes when 2 treatment alternatives are compared. An incremental cost effectiveness ratio is calculated when evaluating costs and outcomes between competing alternatives and represents the additional costs required to produce an additional unit of effect. It is calculated as shown to the right, where C equals costs and E equals effects. So the incremental cost ratio is C2 minus C1 divided by E2 over E1. So let's do an example. If you're spending $200 on drug A and it results in 5 treatment successes, while spending $300 on drug B results in 7 treatment successes, what is the incremental cost ratio? So calculation is 300 minus 200 divided by 7 minus 5, so that's $50. So your conclusion would be that drug B costs $50 more relative to drug A for each additional treatment success. And then we're going to look at the methodologies used. So let's look at the cost minimization analysis first. So the CMA is used when 2 or more interventions have demonstrated equivalence in outcomes, and the costs of each intervention are then being compared. So the CMA measures and compares the input costs of treatment alternatives that have equivalent outcomes. This determination of equivalence is a key consideration in adopting this methodology. Ideally, evidence exists to support the clinical equivalence of the alternatives. In some instances, assumptions are made in the absence of relevant evidence. For example, 2 ACE inhibitors, captopril and lisinopril, are considered therapeutically equivalent in the literature, but the acquisition cost, which is the price paid for the drug, and the administration costs might be different. So captopril is administered TID and lisinopril is administered QD. So a cost minimization analysis would look at minimizing costs when multiple drugs have equal efficacy and tolerability. Another example of CMA is looking at the same drug regimen given in 2 different settings, so hospital versus home health care. So cost minimization analysis is considered the easiest analysis to perform, but use of this method is limited given its ability to compare only alternatives when with demonstrated equivalent outcomes. The next analysis we're going to look at is the cost-benefit analysis. So the CBA. This is a systematic process for calculating and comparing benefits and costs of an intervention in terms of monetary units or dollars. So the cost-benefit analysis consists of identifying all the benefits from an intervention and converting them into dollars in the year that they will occur. The costs associated with the intervention are identified, allocated to the year when they occur, and then discounted back to their present day value. Given that all other factors remain constant, the program with the largest present-day value of benefits minus costs is the best economic value. So in cost-benefit analysis, it can be difficult to assign a dollar amount to a benefit. So for example, measuring the benefit of patient quality of life, which is difficult to quantify, and assigning a dollar value to it. One advantage to using cost-benefit analysis is the ability to determine if the benefits of the intervention exceed the costs of implementation. Cost-benefit analysis can also be used to compare multiple programs for similar or unrelated outcomes as long as the outcome measures can be converted to dollars. Let's also review cost effectiveness analysis, or CEA. This is used to compare the clinical effects of two or more interventions to the respective costs. The resources associated with the intervention are usually measured in dollars, and clinical outcomes are usually measured in natural health units. So for example, LDL values in milligram per deciliter, percent of clinical cures, length of stay. The main advantage of this method is that the outcomes are easier to quantify when compared to other analyses. And clinicians are familiar with these types of outcomes since they are similar to outcomes seen in clinical trials and in clinical practice. So the cost effectiveness analysis is the most common pharmacoeconomic methodology that is seen in the biomedical literature. A disadvantage of the cost effectiveness analysis is the inability to directly compare different types of outcomes. So for example, you cannot compare the cost effectiveness of implementing a diabetes program with implementing an asthma program where the outcome units are different. So for example, blood glucose values versus asthma exacerbations. It is also difficult to combine two or more outcomes into one value of measurement. For example, comparing one chemotherapeutic agent that prolongs survival but has significant side effects to another chemotherapeutic agent that has less effect on prolonging survival but has fewer side effects. We're also going to review the cost utility analysis, or the CUA. So this is the specialized form of the cost effectiveness analysis that includes a quality of life component of morbidity assessments. So using common health indices such as quality adjusted life years, QALYS, and disability adjusted life years, DALYS, the cost effectiveness analysis can measure the quantity of life or years gained, but not the quality or utility of those years. So in the cost utility analysis, the intervention outcome is measured in terms of quality adjusted life years, QALYS, gained. So the quality adjusted life years takes into account both the quality, the morbidity, and the quantity, the mortality of life gained. So the cost utility analysis, CUA, measures outcomes based on years of life that are adjusted by utility weights, which range from 1 for perfect health to 0 for dead. These weights can take into account the patient and society preferences for specific health states. There is no consensus on the measurement since both patient and society preferences can vary based on culture. An advantage of cost utility analysis is that different types of outcomes and diseases with multiple outcomes of interest can be compared, unlike in the cost effectiveness analysis, which can only compare one common unit. The last category we're going to look at is the health-related quality of life, or the HRQOL. This refers to the effects of a disease and its treatment on an individual's function and well-being as perceived by that individual. It is commonly included under a broad umbrella of assessments known as patient-reported outcomes, or PROs. The health-related quality of life is comprised of several important domains. These include physical and mental functioning, role functioning, vitality, social functioning, and general health perceptions. The health-related quality of life assessments can provide important patient-centered information relating to the effects of a disease or treatment on patient functioning and well-being. These assessments are typically developed as either general or generic health status instruments that can be used across a number of diseases and disease areas. So for example, the SF36 health survey can be used for asthma, diabetes, and other conditions, or disease-specific measures applicable to a limited disease population. So for example, the Asthma Quality of Life Questionnaire. Prior to their use in practice, it is critical that the reliability and validity of the health-related quality of life assessments in specific patient populations has been documented. And that concludes the review on page 224.